This series is in partnership with Providence Healthcare and the Edwin S.H. Leong Center for Healthy Aging at University of British Columbia, and we're very pleased to welcome you to our Dialogue on Aging public presentation series, which is on diverse aging-related topics. Before I formally welcome our speaker, Dr. Gauthier, I'd like to acknowledge that those of us who are gathered together here on University of British Columbia West Point Grey Campus, which is located on what settlers refer to as Vancouver, British Columbia. We are gathered on the traditional, ancestral, and unceded territory of the Hunkaminam-speaking Musqueam people, and those of us who are throughout Vancouver or more broadly on the territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh First Nations. I'm honored to live, work, and learn on these lands. And in addition, since this is a virtual seminar, we have people joining us from many locations across the country and outside of Canada as well. And so from coast to coast, I acknowledge the ancestral and unceded territories of all the Inuit, Métis, and First Nations people that call this land their home. So now it's my great honor to introduce our distinguished speaker, Dr. Serge Gauthier. Dr. Gauthier is academic co-lead of Dementia Education Program and Professor Emeritus in the Department of Neurology and Neurosurgery and the Department of Psychiatry at McGill University. He's a clinical neurologist specializing in the development of new tools for diagnosis and treatments for people living with Alzheimer's disease. His contributions to research include design and implementation of randomized clinical trials in order to establish the safety and efficacy of cholinesterase inhibitors, muscarinic agonists, and agents possibly modifying progression for Alzheimer's disease and vascular dementia. Special interests include consensus approach to the management of dementia in different stages, the ethics of research involving people living with dementia, and primary prevention strategies against cognitive decline and dementia. Among his numerous prizes and distinctions, Dr. Gauthier was appointed to the Order of Canada in 2014 and the National Order of Quebec in 2017 for his contributions to advancing our understanding of Alzheimer's disease and dementia, and for fostering the development of research networks in his specialty. So my warm welcome to Dr. Gauthier, and we look forward to hearing your talk. Thank you.
Many thanks, and great to see people joining from coast to coast for good news. Because today we're talking about modifiable risk factors for dementia. So this is part of primary prevention. And I'll walk you through some up-to-date information. Let's see. So it works. So this is me, just in case there was a problem introducing myself. So I'm a retired neurologist. Be careful what you wish for when you retired. First year to write the World Alzheimer Report 2021, and then the second year World Alzheimer Report 2022 on diagnosis and then management. And now I have the opportunity to co-lead a new initiative, which was started by a former care partner, Mrs. Webster, in order to educate people who have the disclosure of having mild cognitive impairment or mild dementia, and their family members, what to expect, how to plan for the future, etc. So the main topic today is the highlights of what is called the Lancet Commission about modifiable risk factors. The publication was in July this summer, and it's part of a global effort to find why don't everyone have Alzheimer as they get old. And just to give you a feel for that, over age 90, nearly everyone has in their brain pathological changes that come with age involving two key proteins, amyloid and tau. But only a third have symptoms. So there are protective factors at play. And what we're going to do today is go through what we know about risk factors and how we can modify them in our daily life. As a general introduction to the topic, indeed, age is the major risk factor for cognitive decline and dementia. So careful what you wish for. You want to live to 85, 90, okay? But then there's a risk of cognitive decline and some of us dementia. The figure that's the most quoted in Canada is 1 over age 65 having Alzheimer's. You may have Alzheimer's disease in your brain but have no symptoms and never get any because there are protective factors at play. The other novelty is that you may have very mild symptoms that will never get to the point of calling it dementia because you die of something else, or there are protective factors at play. And we often hear in the lay press about young people with dementia. It's always striking, a 55-year-old woman. Nowadays, in Quebec, it's a 47-year-old woman coming from a family where every person has a 50-50 risk of having dementia because it's inherited. It's a rare mutation. It's a particular group of people, less than 2% of all people with Alzheimer having a genetic form of Alzheimer. I'll talk about that more specifically in a second. Just a word about sex and gender. It is indeed more common in women than men to have Alzheimer's disease. Other causes of dementia, such as multiple strokes, which are rare in Canada now, or a combination of Alzheimer and small stroke, that is very common over age 85. It's roughly equal between men and women. There are other types of dementia we don't talk about as much, like frontotemporal dementia, and that's more equal men and women. It tends to be in slightly younger people. And finally, another one that you may have heard about is Lewy body dementia. It's kind of a mix of Alzheimer and Parkinson pathology and symptoms. And that's probably also equal men and women. About genetics, that's a question we always get, so let's get it out there. There's very few families in the world that have a specific gene. There's actually 3 of them that we know of, involving 3 different chromosomes that are so strong that you're literally born with Alzheimer. It's dominant inheritance, so you need just one copy from one side of the family and you have the disease. There's a lot of research going on, including Vancouver, which is one of the hubs of research on early onset dementia in Canada. And it's part of a global effort worldwide to find those families. And now we're actually trying to treat the people in their 20s, whereas most of them get symptoms around age 40, 45. So early treatment, controlling amyloid buildup in those families is an ongoing strategy. So genetic dominant inheritance, very rare. And these families are part of a global network called DIAN. Another genetic factor that's more common is a mutation. It's not a mutation, it's a variation of a gene that controls a protein called apolipoprotein E, ApoE for short. And that protein carries cholesterol in the body, into the brain, into nerve cells. And if you have 3 inherited from both sides of the family, you're just average. But 15% of people in our population, 15%, 1/5, have one copy from one side of the family that's not as efficient to carry cholesterol where it's needed. So that's called like 3/4 or 2/4. That number 4, one side of the family, gives you this bit of a weakness to repair yourself if you have a head injury, to recover from a stroke, to learn in school. That's 15% of people. And it's not specific to Alzheimer. If you were to get Parkinson, you'll get it at a slightly younger age. And the good news, to cut to the chase today, is that what we're going to talk about, modifiable risk factors, cancels that risk. So if you have one copy, number 4, from one side of the family, all the modifiable risk factors control, healthy lifestyle will cancel that genetic effect. Okay. Now, if you have double four, you inherited from both sides of the family this less efficient gene to carry cholesterol when needed. That's a special issue. It's called being homozygous, two copies. It's less than 3% of the population, but these people are more at risk. If they have a head injury, it really takes longer to recover. If they need amyloid treatments, they're more at risk of complications. So expect in the near future in Vancouver, as well as the rest of Canada, and it's already happening in the US, there'll be more testing for this ApoE. Not so much to find out if you're at risk, but to find out if you're eligible for treatment in case you have symptoms. So that's it for genetic factors at play in Alzheimer. Over age 90, there's a lot of people with Alzheimer-like conditions. It's just because of age. So don't be surprised when someone tells you, well, I have two of my great aunts, they had Alzheimer when they were 90. Okay, it's not because it's genetic, it's just because they lived to old age. Next slide is me to move. Sex and gender, we said that. Okay, so something specific about Canada. There were some researchers that looked carefully at what was specific about Canada, and then we'll look at the world. So this is a way to display the findings. So I'll need my glasses to look at this small print. This kind of way to put down the risk factors, which we will discuss one by one very soon, is just to show how important they are, not just in the cause of dementia, but in the number of people with that specific factor. So hearing loss is very common, but it's probably a weak factor in having cognitive decline. But because it's so common, it has a high score, 6.5%. Traumatic brain injury, not as common, but very damaging, and so on. So the point I want to make, because we're going to look at the specifics in a few minutes, is that in Canada, obesity is high, hypertension is high, and like in the US, it's not so much a lack of education that's the issue. The point being that you have to take all these modifiable risk factors in context. And careful also when you read about a special diet being good for your brain. Well, depends where the study was done. Like green tea is probably good for you, especially if you live in Japan, but it's not sure that it's so healthy to drink only green tea in Vancouver. Just be cautious about where the information came from, and there may be population-specific recommendations. But let's go worldwide now. The Lancet Commission update. The context is people are living longer. There's more data being collected by every country, including Canada, about why do some people live well and others get sick. The new modifiable risk factors this year, and we'll speak about them more in detail in a minute, are untreated visual loss. So if you have cataracts, get them operated on because you're modifying a risk factor for dementia. We'll talk about how is that possible that untreated visual loss would be a factor. And high LDL cholesterol is a risk factor. That's really not a surprise. We've known for some time that having bad cholesterol is a risk factor for heart attack and stroke. And in Ontario, they've developed a strategy that has worked well until the pandemic. What's good for the heart is good for the brain. And they were treating imminent stroke, transient ischemic attack, as aggressively as if it was an impending heart attack. And there were less people with dementia until the pandemic in Ontario than expected. And that was also the case in parts of England and Scandinavia. So now we're going to look at the 14 modifiable risk factors, but many of them have in common heart attack and stroke. So if you can prevent heart attack and stroke, you prevent, to some degree, risk of dementia. So this is now the official, looks like a snake or hippocampus. I'm not sure what to call it. But the point here is that some factors are more important in childhood, such as education. So if you stay in school until at least grade 15, secondary grade, you're less at risk of dementia 60 years later. Huh. It's because your brain builds a reserve that will last a lifetime. Also, if the child is able to learn a second or third language, good for you. It's never too late to learn a second or third language. It's been shown by studies done in Canada and US that bilingualism adds resistance to aging to the brain. And then you have in midlife, in yellow, the bulk of the modifiable risks. This is roughly age 40 to 65. So that's important. It's people still at work, still having children at home. High HDL and cholesterol, we've already mentioned. We'll talk about the specifics in a minute. Depression, traumatic brain injury, physical inactivity. That's a high one in North America. Diabetes, that's high now worldwide, including India and China, as well as the US. Smoking, hypertension, obesity, and excessive alcohol. So we'll talk about the specifics, but the point here is that midlife, 40 to 65, you have a lot of things you can do to prevent brain aging 20, 30 years later. Many of the items have in common heart and stroke prevention. And late life, because that's where it seems to matter the most, is social isolation. That's a hard lesson from the pandemic, isn't it? Social isolation, especially if you already have some other factors, hesitation in your interaction with people, at risk of falls. Social isolation is an additive factor to possibly having accelerated cognitive decline and dementia. Air pollution is a surprise. It came out 4 years ago. Some countries like Pakistan and China, you hear about them every day. In Canada, we were spared so far, except for forest fires more recently. But air pollution seems to be a factor in the population at large. I'm not sure it's late life so much as midlife, but time will tell. And visual impairment, that's the new one. And we'll talk about that more closely. So that's 14. And just to tell you, I'm hoping next time in 3 or 4 years, there'll be additions, such as healthy gums, buccal hygiene, taking good care of your teeth, which touches a bit about having good nutrition, will be a factor. And the other one is sleep hygiene. So people who have difficulties falling asleep, insomnia, chronic insomnia, maybe it's a risk factor for some aspects of cognitive decline, but the data isn't all in yet for that. So let's go through them together. Less education, I think it's pretty obvious. This is from a societal perspective, and it's never too late to catch up. So if people who dropped out of school for whatever reason at age 14, they can go back as in adult courses. And it's also when you retire much later, go back to school or do whatever you felt like doing, but you never had the time. Bilingualism, I highlighted already. So this is a modifiable risk factors, especially for certain countries, such as rural India, rural China, Bangladesh, etc. Perhaps some parts of Canada in the north. Hearing impairment, so that's possibly because you cannot hear people, so you cannot communicate as well. Maybe there's a bit of social isolation on top of that. These are hard numbers. It's been really been well documented that you have untreated hearing impairment, your risk of cognitive decline and dementia is higher. And because it's so common, it's 7%. This is one of the highest scores. So get a hearing aid if you need one. Make sure your province will pay for the hearing aids if it's not already the case. And don't be shy about wearing them. LDL, we've already talked about. So if you need a statin, just take it. And there may be other good things about taking statins, but for now, let's say treating bad cholesterol is good for the heart, it's good for the brain. And the old concerns we had about statins, I think have been largely offset by the benefit of taking them if you need them. Okay, 7%. That's a high score. It means a lot of people need that, especially in North America. Depression is a more complex topic. It's been known for years that if you have unipolar, not bipolar, depression, so recurring depressions before age 65, you're more at risk of cognitive decline later in life and dementia. The difficulty is that many times symptoms that look like dementia are actually look like depression or actually early dementia. Or you being aware of cognitive decline brings about anxiety and some depression, social withdrawal, etc. There's been no clear mechanism demonstrated yet why would someone with recurrent depression be more at risk of cognitive decline. But it's been shown for schizophrenia and to some degree bipolar disorders. So this is an uncharted area where you have a chronic primary psychiatric disorders possibly causing or being associated with cognitive decline and dementia. Message: if you have depression, just treat it well, whether it involves medication or psychotherapy or change of your social interactions, etc. Traumatic brain injury is important in Canada because our kids go to play hockey, and many of them now play soccer or European football. Head injuries are bad. Just speak to any kid who had a concussion. They're not at their best for a few days. And those who have double 4, ApoE44, or perhaps even more at risk. And at one time, quite frankly, we thought, should we screen kids before they go into contact sports? Finally, it was decided not to for ethical reasons, but let's make sure our kids wear their helmets and avoid the head contact even with a helmet. And the extreme of that phenomenon, head injuries leading to dementia, are the football players, the NHL players who had so many head injuries that their brain was full of not amyloid so much as tau changes in the other protein involved in dementia. Physical inactivity. So, surprise? It's important in North America, and I worry about our grandchildren who are now on the iPad or iPhone and are not doing so much physical activities. The good news is that it's a relatively easy risk factor to modify. So just be active, and that could be just walking more. It doesn't have to be running. It could be with your dog, but it's better if it's with other people. That's another practical message. Whatever you do to improve your health, manage risk factors, do it with other people. It's been clearly shown that, let's say, reading books is okay, but being part of a book club is better. Interaction with people matters. So I'll come back to that at the end, but I'll say it now in case I forget. Whatever you do for your brain, like doing some kind of mental exercise, if you do it with a small group at the same time, you get more out of it. Diabetes, yep, it's increasing in numbers. Type 2 is more common. We're not quite sure how diabetes and insulin resistance in the brain plays into the risk of Alzheimer's disease in particular. But there are anti-diabetic medications now being tested to treat Alzheimer's. I'll come back to that at the end. Smoking, less an issue now in North America. This is part of the stroke and heart attack prevention strategy, so I'll say no more about that. Obviously, nobody's smoking in this audience. Hypertension, so high blood pressure, the first number, systolic, you need to treat it. If you exercise and losing weight, cutting down on salt intake is not sufficient, then you may need a pill, maybe 2 pills. maybe over age 80, you don't need 2 pills, you need only one. This is adjusted over time. Yeah, hypertension treated, good for the heart, good for the brain. Obesity, so part of the package about diabetes, high blood pressure, high cholesterol. You see, it's kind of a cluster of risk factor, and not easy to fix. If you really want to treat obesity, there's various options available now to Canadians. Excessive alcohol. That's an interesting topic. There was a time we used to say 2 glasses of wine a day, good for men, 1 glass a day for women. We don't say that anymore. We say you don't need alcohol at all to live healthy. If you like wine, 1 glass a day would be the maximum recommended. So make sure it's a good one, maybe from BC. Less is better. We changed our view about that in Canada. During the pandemic, maybe we all went a bit overboard. Now we have to cut down to 1 glass a day on average. Social isolation, unfortunately, as I said, was a hard lesson from the pandemic. Don't leave old people alone. So I hope you have dementia-friendly communities. You have neighbor watch approach. Make sure, especially when you retire, you join some kind of social activity, community, kitchen, whatever you like, just go for it. And air pollution, we've already talked a bit about that. Not so much an issue in Canada, except for the forest fires, but big issue now in Southern Asia. And visual loss, that's the new one this year. It's common. And the evidence we have so far is that if you do have cataract extraction, you actually decrease the risk of cognitive decline and dementia. Go for it. Bon, what does that mean? Well, that means you have something you can work with, whether you're 40 or 65 or 85. You can adapt your lifestyle based on your individual risks. There'll be more added, as I predict. Gum hygiene and sleep hygiene, I think, will make the list next time. It's been shown that if you modify these risk factors, you reduce the risk of dementia by nearly a half. That has a huge social impact. Less people with dementia. So you live to 90, whatever, but then you die before you get dementia, kind of thing. You move the years where you would have decline to beyond your life span. Well, now what do we do about that? I'll just show you a couple of examples, many of them from Canada. There's a cognitive training strategy that was developed in Montreal. These were people like you, interested in prevention. Maybe they were complaining about their memory occasionally, but nobody had dementia. And they were offered to join a study where over 3 weeks, they would have a small group, like 5 people with a coach, and they would be trained for their memory, and they would have some homework to do compared to people waiting, the control group. And what's new, it just came out this year, is that there was an immediate difference after the treatment at 3 months and then 6 months. But 5 years later, there's still a difference. And look at the number D, MoCA, that's the memory test, so-called, that is known worldwide, developed in Montreal. And look at the straight line. People who had the cognitive training 5 years later, they're maintaining their ability to answer this very difficult test. Wow. Okay. What else we have? The people in Finland decided to put together the known modifiable risk factors and deal with them all together versus usual care. So that was called the FINGER study, Fin for Finland. And the age range, you see 60 to 77. This is the study design. So you were randomized to having nutritionist, making sure you eat enough fish. Probably in Finland, it's 3 times a day instead of twice a day. Exercise with a group. Cognitive training with a group. Social activities, I don't know what that was, but it was variable, and vascular risk monitoring, which was probably the best thing, and versus regular care for Finland. And 2 years later, what was found is that there was a difference in the speed of thinking. Processing speed was higher if you were in the multi-intervention domain, if you get the full package. Executive functioning was also different, better. And there was not much difference for the memory. So message is, after 2 years, if you have the full health package compared to usual care, there's a measurable difference on some aspects of cognition. The nice surprise is 5 years later, 5 years later, there's difference still for cognitive measures, lower risk of cardiovascular events, lower risk of functional decline, lower risk of chronic disease, and it's worth the cost from a Scandinavian perspective. I hope Canada will go that way, but we need also to prove it, because you're having a big package of intensive care for people compared to usual care. And the benefits may be more in 5 years than in 6 months. Okay. So now they're modifying their design to include an anti-diabetic drug. So just to show you, metformin, which is a drug known to many of you because it's one of the old anti-diabetic drugs, it's now part of the package that people get versus control. And we'll see if lifestyle interventions plus metformin, modifying some aspect of glucose metabolism, these are people without diabetes, does it make an additional difference? For Canada, we did something called Synergic. This is equivalent to Finger, and it was run by Dr. Montero Odasso and all over the country, including BC. And I'll show you the design. So it was cognitive training plus physical exercise. So that was the package. And some people were getting vitamin D supplements. Okay. So it was a combination, cognitive training in a small group, physical exercise, small group, and vitamin D as an option, randomized. And what happened after the treatment, there was, as expected, higher performance on some of the cognitive tests. Perhaps most practical message, the vitamin D did not add to that. So you don't need supplements of vitamin D to improve your cognition. You just need vitamin D to maintain your bone structure. Okay, prevent osteoporosis. And now they're moving to a second phase, which includes lessons learned from the pandemic. So the exercise could not be done as a group during the pandemic because of this restriction to meet with other people. So there was a shift to online individual at home exercise and cognitive training. So this is good because it means that people who live away from Vancouver, away from Montreal and Toronto, may have access to programs that have been well designed using remote training and eventually remote assessments. So some of the memory tests that are used in these studies, now we're learning to do them on the phone or online. So more people will have access to studies and eventually benefit from these therapeutic approaches. So to finish, I'll just mention to you that we have, as part of the dementia education program at McGill, various resources. They're all available online, free of cost. The one I'm most proud of is the one at the upper left. It's the companion guide. It's a booklet that we wrote for people who just get the diagnosis and want to know about the stages, what to expect, and also for the family members or friends or care partners. It's written for both. It's available in 15 languages, including Ukrainian. And go online and you get your copy online. If you want a hard copy, just go on Amazon. There's a McGill Cares, so that's small talks, half hour or so. There's 110 of them. You can go choose the topic of your choice. World Alzheimer reports I mentioned briefly. These are big chunks of information, but it's up to date diagnosis and management. Virtual support group, especially for people younger than 65, because they have special needs. Public lectures, trusted resources. There's a new training program, a 10-module program we just put online. That's the one on the bottom right. It's also free of charge. And for fun of it, if you do all 10 modules, you get a certificate. And join us on what do you call media, social media, if you want to have updates. There'll be soon some discussions taking place if Health Canada approves one of the new anti-amyloid drugs. How do we use them across the country?
Thank you so much, Dr. Gauthier. Such a fascinating and interesting talk, integrating so much research about modifiable risk factors. I learned a lot. So we'll open it up now for questions from our audience. And you can write your questions in the chat, and I will pass them on to Dr. Gauthier. We do have one question already there that we could start with, which is a question about alcohol. So it says Canada's guidelines on alcohol and health recommend 1 to 2 standard drinks per week. Any comments compared to your comments about 1 drink per
week? That's discouraging. Yeah, there's a trend to really go much lower than we used to have. Yeah. Yeah. What can I say?
Yeah.
So make sure it's a good one.
Okay, we have another question here, which is, what would you recommend? What are some of the best ways to get cognitive training? What does that look like?
Good point. There are on the market various gadgets, but none of them, to my knowledge, has had the same kind of scrutiny and randomized trials like we just illustrated. The one from Montreal, it's called MEMO, MEMO plus. So you can look it up, MEMO plus. I was hoping that the lead author of that study, Dr. Belleville, would actually put the MEMO plus online for people to use. We'll work on that if it's not already done. The Synergic, SYNERGIC modules, maybe they can be put online since they were well tested in Synergic 2. Maybe I can ask Dr. Montero Odasso about that and get back to you. And maybe we can let our viewers know about that.
Okay, thanks for that. Okay, the next question that we have here is, with the internet and the widespread use of technology, rather than, which means that people don't have to memorize as much, could young people be at increased risk of dementia because they're not using their brains in the same way?
Good question. I'm sure they're using their brain. It's just different way than us baby boomers, and of course you're much younger yourself. But yeah, it's a different way. And there was one researcher in neuropsychology at McGill who was trying to figure out what will be different in the brains of our grandchildren compared to baby boomers, the grandparents. There'll be differences in which part of the brain is most active, even while driving a car. So yeah, there'll be differences. And I worry more about the lack of physical activity and the diabetes than the fact that they use more iPads and iPhones than we did.
Okay, thank you for that. So another question we have is, could you please comment on how to encourage a loved one with symptoms to seek treatment? Or maybe
yeah, that's not the topic today, but it's an important question indeed. So the word is anosognosia. It's lack of awareness. It's about half of the people with Alzheimer, they deny they're having a problem. The short answer is we can pretend we're both seeing the doctor for our checkup. It works sometimes. And if you are welcomed at the clinic, you feel like coming back and you break the ice, so to speak. So, okay. And then you have confidence and it gets better. But indeed, question is quite appropriate. But you need a diagnosis made by a healthcare professional to get access to many of the resources that are out there. So keep trying. The trick that has worked best in my experience is okay, let's both husband and wife go together for a checkup, or both sisters, if that happens to be two elderly ladies that are sisters. Come, let's go get a checkup together. And yeah, it breaks the ice, and then okay, he's fun. He has a bow tie. He can be fun. That doctor. Let's come back. Let's go see him again.
Yeah, thanks for that. Yeah, and there's lots of interesting work people are doing around trying to break down that stigma of dementia, which hopefully over time will help people feel more comfortable seeking help and diagnosis. Yeah. Okay, so we have another question here in the chat, which is, why are all of these health issues addressed after the fact and not before the disease is diagnosed?
Excellent question indeed. So that's we're trying to fix that, and it's going to be a shift in the healthcare system as well. Even in Quebec, with our difficulties with the budget, we're going to try to go for prevention, and for dementia, clearly the roadmap is there. We know what needs to be looked at, and it starts very early in life, as you heard, and midlife is the key location. So we need to convince our regulatory health authorities, yeah, prevention in midlife, especially midlife, 40 to 65, all the cardiovascular risk factors. Ontario made really a good case for that, and they were successful until the pandemic. Less stroke, less dementia. So the big provinces maybe can prove that with their available information, prevention for heart attack and stroke has an important impact on people's life duration, life quality, and we can add now, please have a look at their cognition.
Yeah, so it sounds like it's been a process of discovering what the modifiable risk factors are, and now we need changes in policy and funding to help that preventive approach. Okay, next question is, how does the loss of hearing promote dementia? I can understand the major loss of hearing that results in a person being isolated, but how would a partial loss of hearing contribute to possible dementia?
Yeah, we're not sure, quite frankly. It's just an association that was discovered when looking at lots of people worldwide. So, as the person just said, it's partly because you lose some access to your environment, and you lose some ability to interact with people. What's been shown is if you fix that, easy. In most people, contrary to visual impairment, which may be due to other causes like macular degeneration. But hearing, which can be helped in, I think, most people, yeah, you're back. You're back to your bridge club. You're back to more stimulating life, and you do modify the risk of progression.
Okay, thank you. The next question is, are the reduction, I think this means that is addressing modifiable risk factors cumulative or overlap with each other?
Yes, excellent question. The point has been made, especially for the vascular risk factors. If you treat only the high blood pressure, but you don't treat the cholesterol or the obesity or the diabetes, you don't get as much protection for heart attack and stroke. I think it's obvious to everyone. So if you address all four in an individual who's smoking, obese, not active, and has high cholesterol, yeah, he'll do better. So very good point. You need to address, especially cardiovascular risk factors. That's been well demonstrated altogether.
Okay. Someone else comments that they read shingles vaccine is related to lower risk of Alzheimer's. Do you know if
It's
that's
a bit
true?
early to say that, but I think we should consider having it indeed. Not for that reason. It's just very miserable to have shingles.
Shingles,
But
yeah.
the issue of infections and the risk of dementia is not as clear. It's like cancer. Having cancer lowers the risk of dementia to some degree. We have no idea how, but that's going to be studied, and doesn't mean it's a modifiable risk factor, but it means if you have cancer. One thing that came out of Vancouver 35 years ago is if you have chronic arthritis, you lower the risk of dementia by 30%. Thank you, Dr. McGeer, because he was right. So it's possibly not because you have arthritis, but because you take long-term anti-arthritic medications and you suppress silent neuroinflammation. We're still trying to prove that you can treat neuroinflammation and modify the progression of Alzheimer. The difficulty is who has neuroinflammation? It's hard to measure unless you're using fancy scans and lumbar punctures and maybe blood tests, but we're working on that. So back to epidemiology. So if you have chronic arthritis, small consolation, your risk of dementia is much lower.
Okay. Another question is, if you have been low vision from birth, does that impact risk of dementia?
Good point. Probably not answerable with the information that the Lancet Commission had available. It was more like the usual macular degeneration, cataracts kind of etiology, later onset, indeed.
Yeah. Okay. When you talk about cognitive training, is it specific to things that improve memory, or are word games, number games, Sudoku, Wordle, etc., also part of brain training?
Excellent question indeed, because it was easy to show some benefit for memory training, what you call working memory. But what you got out of it is you learn maybe you can learn one extra word out of 5. It was not really practical and useful. If you combine memory training with executive training, you think faster, and you get to make the right decisions more often and faster. So indeed, it's better to combine not just memory. You combine whatever is available. So memory plus something else is the way to go. We need to get better at this. If there's any neuropsychologists out there, it's a gold mine. People are eager. But indeed, memory plus executive ability, it's been tested. In the games that were mentioned, like number games, etc., I'm not sure if they specifically help you in specific ways. Maybe calculation is important for you, maybe not for the average person. So that would fall perhaps under speed of thinking kind of abilities, more like under executive abilities category rather than memory. Yeah.
Hey, what about sleep quality and dementia risk?
So I did mention that it's possibly a risk factor that's building up with more evidence. Honestly, the best evidence we have is Parkinson. So if you have impaired sleep, what you call REM behavior disorder, which is the stage of sleep where you dream, people who have Parkinson in their brain, no motor symptoms yet, they do have that sleep abnormality. It's also true for Lewy body dementia. We mentioned it briefly as one of the causes of dementia. It's Parkinson and Alzheimer mixed together in the brain. So they also have this specific sleep disturbance that they move around in the bed while they're dreaming. But that's probably not what most people here are referring to. I think most people refer to, I cannot sleep as well. I need to sit rather than lie flat because of discomfort on my spine. The sleep apnea, of course, that everybody is aware of. And also as we get older, we have shorter nights. We get up when we wake up. And then some of us go back to bed, others, they go to read. Is this bad for the brain or not? Well, I'll share one secret. The amyloid out in your brain that builds up, during your sleep, especially slow wave sleep, that's when you clear the amyloid out of your brain. Huh. So we as much as feasible, we need to have regular nights, all the usual sleep hygiene strategies. Don't look at something too exciting, not too much blue screen or green screen before you go to bed. Read if you cannot sleep quickly, just go back to read something not too exciting. Um, no alcohol before going to bed. It doesn't help, and it actually interferes with REM sleep and slow wave sleep, which is the one we want. So more to follow on that. Stay tuned.
Okay, thank you. I think you answered a few of our questions. We had a few about sleep and one asking if Parkinson's was related to dementia. So thank you. You mentioned that chronic arthritis lowered the chance of getting dementia, and they wondered if you could comment further on that.
Wait, it was an observation made by Dr. McGeer in Vancouver 30, 35 years ago, and it's not specific to osteoarthritis. It's not specific, rheumatoid arthritis as well. And the explanation he offered, and it's still the one we think is best, is that the chronic use of NSAIDs, non-steroidal anti-inflammatory drugs. The old ones like Edocid, Domitacin, they're the ones that upset your stomach. So don't take these medicines to prevent dementia if you don't have arthritis, because the risk of having a GI bleed is higher than having dementia. Okay, they're not easy drugs to take. But when we tried in the 90s, this particular drug, a strong NSAID, in people who had early Alzheimer, there was no change in the rate of progression. Perhaps it was too late. We would need to treat people before they get symptoms. So it's on the map. It's one strategy we're developing in Canada. We have people interested in prevention, even medications if they need it. So you have, let's say, people over the years who are starting to be a little slower in their ability to answer questions, but they're still independent. And maybe we have their blood profile. We know they have a bit of inflammation. It could be from the brain, could be from some other part of their body. Maybe they'll be interested to try a new generation of anti-inflammatory drug. And we'll see. So amyloid and tau is what you hear about the most, but inflammation is the third one. And of course, glucose metabolism, insulin resistance, diabetes kind of changes is the fourth factor that is understudied to prevent brain aging and dementia.
Okay, thank you for that one. Are modifiable risk factors more relevant for vascular dementia than Alzheimer's?
Excellent point. Indeed, what we modify the most is the vascular component of dementia. Right on. Absolutely. We don't know yet how to modify amyloid buildup and tau pathology spreading. Inflammation actually may be a better target than other factors that we've mentioned so far for Alzheimer. Yeah. So indeed, that person is very, very sharp. Absolutely. The vascular component of dementia is actually quite modifiable, even more than just Alzheimer, plain and simple. Quite true.
Next question is, with the legalization of recreational use of substances such as marijuana, do you predict any impact on dementia statistics?
We have no idea. We have no idea. So people are actually measuring this carefully. There's special grants given for that. The only positive thing I can say about some of the marijuana byproducts is that it can help some of the symptoms, including sleep disturbance in people who have dementia. And it may help avoid antipsychotics, but that's a discussion for another day. They're used for symptom control, avoiding other drugs that are not as safe. But indeed, I'm also concerned. about recreational use of marijuana in people who may be at risk because they're ApoE44, for instance.
Mhm.
Yep.
Okay. There's just a comment that Posit Science based in California has extensive brain health exercises, which are used by the Mayo Clinic. So that's something that maybe
Good,
people
indeed.
check.
I think in Florida you can find a lot of resources, and maybe we can access online to some of them.
Yeah.
Yeah,
Yeah.
they're very good about that. It's something Vancouver could also build. The UBC, maybe if you have a strong neuropsychology team, you can build on that.
Okay, and one more. Thank you for typing this one in because I'm not able to answer raised hands. Could you please comment briefly about hearing loss and cognition? They wanted to hear more about that.
I think that was already asked and partially
Mhm.
answered.
Yeah.
Indeed, it's not obvious why correcting this very common risk factor, hearing impairment, would quote prevent dementia. It's really more, it increases your ability to interact with your environment, your social environment, and that's part of that's good for the brain.
I'm just having a quick check to make sure I've got all the questions. What progress is being made in very early diagnosis of dementia?
Good question. Indeed, we have now blood biomarkers, so a blood test. These are fragments of the tau protein that I mentioned that builds up in the brain as we get older. Some parts of that protein leak into the blood, and they have numbers. So there's one number 217 that seems to be the most sensitive one. So if it's high in the blood and you don't have chronic kidney disease, because there's factors at play in how much stays in the blood. But if it's high, this 217, it usually means you have high amyloid in your brain. Huh. It's because amyloid buildup often coincides with tau pathology, and that's the tau leaking into your blood. So we're very close. Canada actually plays a big part of that research. We were lucky because about 10 years ago, we started a group of volunteers at McGill. We have like 700 of them now. They come every year, lumbar puncture, 3 PET scans, blood work. And we send the blood to Sweden, where they're very clever at measuring things before everybody else. And they were able to find, yeah, if you have amyloid in your brain that's higher than normal, whether you have symptoms or not, these fragments of tau protein are high. So expect in the next year, even in BC, when you go see your family doctor or your local clinic, whatever setup there is for assessing people with cognitive complaints, they may do a blood test. That may include ApoE, that we mentioned already, and the p-tau, phosphotau, the tau fragment, 217. And if it's high and you're ApoE4 or 44, you would be sent straight to a special clinic run by Dr. Sion, probably, where you have access to the new treatments to remove the amyloid out of your brain. You would be fast-tracked.
Wow. Very interesting. Thank you so much. There's one last question that I can see here, which is it true that people with dementia are not aware that they have it?
That's the point we had earlier.
Yeah.
Mentioned the people who don't want to go. It's because they're not aware. Anosognosia is the medical term, or lack of awareness. Indeed, it's pretty unique to Alzheimer, and it's about half of the people. It makes it easier on them in a way because they're not anxious about symptoms they don't feel they have. Actually, I think the opposite is also very bad. If you're too aware of what you're losing and what's coming, the anxiety that builds up is so bad. It eats you alive. So in a way, anosognosia is protective for people who have symptoms of Alzheimer's disease, but it's harder on the family because, yeah, you cannot let the grandpa have the key to the car or the checkbook and the credit card. Yeah.
Thank you. So that brings us to the end of all the questions that have been asked. I want to just extend my deepest gratitude and thanks for your talk today. It was wonderfully interesting and I learned a lot, and I'm going to work on my exercise and sleep, I think, after this. So thank you so much. Very, very much appreciated. And to everyone in our audience, thank you so much for joining us today. It's because of you that this series is successful, and we keep coming back, so thank you. I'd like to invite you to our final talk of this year, this calendar year, which is on December 12th. It is our next Dialogue on Aging public presentation with speakers Dr. Kathy Pechora Fuller, who I think was in our audience today, from the University of Toronto, and Dr. Walter Witchett from the University of Montreal. And their virtual lecture will take place from 2 to 3:30 on December 12th. And it is on the topic of how sensory health promotes cognitive health.
Excellent.
So thank you again, Dr. Gauthier. Thank you, audience. And we hope to see you all back on December 12th. Oh, and I forgot to tell you earlier, I'm Julia Henderson, assistant professor in the Department of Occupational Science and Occupational Therapy here at UBC, and co-chair of community engagement with the center. So my many thanks to everyone.
Bye.
Good afternoon. Bye.